So we'll now go to the pre-recorded session by Professor Nicolaas Schaper. As I mentioned earlier, he's a professor of endocrinology in Maastricht. He was the founder and coordinator of the first Eurodial study, and also one of the founders and the chair since 2005 of the International Working Group on the Diabetic Foot, and also the chair of the International Symposium on the Diabetic Foot.
Good afternoon, everybody. Here I'm back again with the great help of Adrian and Eric of the Award Event Services. They helped me to get this, to record this presentation. It's a bit strange. I would have loved to be with you, but that's how it is with COVID. My talk will be about how long to cast in acute Charcot foot in total contact cast. That was the topic I was given by Andrew. And I can already tell you the answer. So if you want to have coffee or tea, you could leave the room now, because the answer is I'm not sure. But I will try to come up with a practical advice which could be helpful for daily practice. Causes and consequences of acute Charcot. We have to realize that when we talk about treatment. This is, of course, my clinic, a typical patient who developed Charcot, both legs, and you can see that he developed also an ulcer. So that's the outcome of many patients with Charcot, a deformed foot that ulcerates with an elevated risk of amputation. And of course, probably due to the neuropathy, and clearly elevated risk of early cardiovascular death. So what are we talking about? What is the disease? Well, we're not sure, but in the last decades, slowly, I think a kind of consensus has evolved what we are talking about. 20 years ago, I said, I don't know what Charcot is now, at least. I say, okay, we've got a vague picture of what is going on. It probably starts with inflammation. So it's an inflammatory condition in a neuropathic limb. And that inflammation could be due to a trauma, could be due to operation, could be due to an ulcer, etc. Then that results in bone resorption with or without joint destruction, with and without ligament rupture. And then this bone resorption, joint destruction, and of course the rupture of ligaments, which puts a huge stress on the different bones of the foot, can result in fracture, one or more. These fractures then can dislocate, become malaligned during treatment, and at the end of the day, you can end up with permanent foot deformities. How to diagnose? Well, the clinical presentation is relatively easy. It's a hot, red, swollen foot with edema. We used to say that the X-ray was the definitive diagnosis, because you could see there the bony abnormalities like fractures, but nowadays we realize that in the early stage, because I said it starts probably with inflammation, you can have inflammatory changes without clear X-ray abnormalities. Then a bone scan can help, high sensitivity, but poor specificity. It shows increased uptake in early and late phases, and an MRI is, if you have it, is a better diagnostic modality that will show in those cases bone marrow and tissue edema, and once there are fractures going on, you will see microfractures or larger fractures. You will see that multiple bones are usually involved and are kysts. So this is how you diagnose it. But can you use some of these diagnostic modalities also to monitor disease and help you to decide how long to treat the patient? Here is an example. Here you see an X-ray with a fracture through the cuboid, the white arrow, and you see a clearly talonavicular dislocation. This is a typical stage 1 Charcot. Well, how to treat such a foot? Well, all the guidelines state immobilize. Immobilize in a knee-high total contact cast. And how are you doing that in England? Well, Fran Gain published a beautiful study, and I think one of the important studies on this topic in Diabetologia in 2012. It's an audit in the UK, and it's about 288 patients. And if the patients, then the patients were treated at presentation with a non-removable cast for 1 to 3 week changes in only 35%, and a removable device was used in 50%. And if you use a non-removable total cast, at least in this audit, there was time to resolution of the Charcot 9 months. If you use the removable device, 12 months. So this clearly underpins the advice giving in several guidelines to immobilize in a knee-high total contact cast. Of course, it's not a randomized controlled clinical trial, but for me, there is very little question here because we talk here about a fracture, and at least in stage 1, so once the bones are clearly involved and it is fracturing. And for instance, American Orthopedic Association clearly states that if you have a fracture in the midfoot, it should be immobilized and it should be used in a cast. So also in non-Charcot patients, so patients with a foot fracture, at least of the midfoot, there's a clear advice to immobilize them in a total contact cast. So I think there's little debate there. But unfortunately, in many centers in Europe, in America, still many of these patients are poorly treated. How long are they treated? Here I made a summary, probably not complete, but here you see in the center the study of Gain, the number of patients, 219, 43 weeks was the median treatment of total contact cast. And if you go up, one of the first studies of David Armstrong, he showed that he could treat them 18 and a half weeks before going out of the cast. And the latest study is from Griffiths, and that's a median of 19 weeks. And also our data, which is Romer's, is the same, 17 weeks. But there are other studies, like the GAME study, Stark study from America, much longer. And why? I don't know. It might depend on the severity of the abnormalities when the patient starts the treatment. So these studies are probably very difficult to compare. Maybe different casting techniques were used. So this is a difficult topic to determine what is your optimal treatment phase. At least in our center, we treat them 17 weeks at median, although we can go up to 34 weeks, and we have 0 recurrence. So we follow a very strict regimen, and with that, we see very little problems. So what are we talking about? A knee-high non-removable total contact cast. Here is a beautiful picture. This is actually the technique we also used, but I took it from the publication of Griffith. You can find it there. You start with felt padding under the foot, then you put a cotton tube bandage around the lower leg, then you use silicone strips to protect the lower leg, and then you use only an inner layer of plaster of Paris, and that you can mold around the foot, and even sometimes realign some of the abnormal deformities, at least in the early stage when the foot is very flexible. And then you put a layer of fiberglass as an outer layer. At the end, you have a rather lightweight cast, much less weight than a plaster of Paris cast. And then you put a shoe around it so the patient can walk on it. Although the gold standard, it's not without risks. There are complications of a total contact cast, ulceration. We seldom see them, but they have been described. Muscle atrophy, that's one of the problems. If you immobilize the limb for half a year, of course, there will be marked loss of muscle. Osteoarthritis, we've seen one dramatic case of knee osteoarthritis in the contralateral leg. And for that, we learned that if you elevate one foot, you should always elevate the other foot in an identical way. So the healthy leg is not abnormally loaded. So think about that. The patients have, of course, an increased risk of falls because of the neuropathy. And it will immobilize the patient, even if you allowed weight bearing. And studies have shown that when you allow weight bearing, up to 3,000 steps are taken. Well, we advise to take at least 10,000 steps a day. That can add to social isolation and, of course, to metabolic deterioration. So total contact cast is not a simple treatment, not without risks, and should be as short as possible. So what is short? The aims of the treatment is to unload the foot in order to mitigate the inflammatory process. Already Hippocrates said, don't walk on a diseased leg. So that's already there for 3,000 years. The second one is we have fractures here. So we have a fracturing disease. So you should stabilize the fractures and to facilitate alignment of fractures and joints. I think that's sometimes forgotten in the discussions. And then finally, you have prevention of deformities. And that one is difficult, the last one, because once you've treated the Charcot patient and you have the impression that the inflammatory process has disappeared, and there's healing of fractures on your X-rays. Still, 1 and 2 years after remission, there is continuous changes in the structure of the foot. Shown here in this study of Hastings, that the cuboid height decreased 1 or 2 years after remission of the acute Charcot, which means that there is progressive development of a flat foot, despite that you have treated the Charcot. So probably we cannot completely prevent deformities. But we know that if you have delayed treatment, it is associated with more deformities, at least in some small studies. If you have delayed treatment, it is associated with longer healing time. A study of Charcot showed that already in 1998. 63 days early treatment, 100 days in delayed total contact cast treatment. And Chantelot has shown in several series of his clinic that healing after early versus delayed total contact cast is associated with an increased risk of deformities. In early total contact cast, so rather immediate treatment of the patient, only in 1 patient there was a deformity at 11, and in 13 patients who were treated months after diagnosis, you have 12 deformities, which is of course not very strange if you think that there is a fracture and you have that patient continued walking because of the insensate foot on that fracture, and you have progressive malalignment. So treat them early, treat them with a non-removable cast. I showed you in the earlier slide that if you give the patient a removable cast, the patient will remove the cast. So how to monitor disease activity? Well, I think it was David Armstrong who introduced the idea of bilateral temperature measurement using a standardized technique in at least 6 regions of the foot. Some centers use 10, some centers use 7, we use 6. And usually it is stated that a 2-degree difference in Celsius is a clinically relevant difference suggestive of Charcot disease activity. In a nice study of Delamore, it was shown that if you have the same observer doing repetitive measurements in a Charcot foot, a difference of more than 1 degree Celsius is a relevant difference. So there is probably still something going on in that foot. But it doesn't mean that if the difference is more than 1 degree Celsius that you should continue treatment. I'm only trying to say that that is a sign that still something is going on. So yes, you could use temperature, and many people use a difference of 2 degrees. As long as it's more than 2 degrees difference, there is still disease activity. The problem here is that if you think about fracture healing, at the later phases of fracture healing, there is remodeling. And that remodeling is also accompanied by an inflammatory process because there is removal of callus and resorption of callus. And probably in that phase, there is also elevated temperature. And in our clinic, we frequently see that, not frequently, but we sometimes see that patients in the later stages of their cast treatment, they still have a 2 degrees elevation of temperature, while the X-ray clearly shows a healing of the fractures. We then ask the patient to sit and lower the leg, and if you look at the leg in dependency, and you immediately get, again, warmth, swelling, hyperemia, we know that the disease is still active. Well, if the patient lowers his or her leg and it remains the same color and you don't have any signs of an acute inflammation, we frequently move them to the next phase of treatment. So temperature is very helpful, but it's maybe not the best marker. So other people have used quantitative bone scan, MRI, and PET-CT scan with FDG. Here you see a nice study of quantitative bone scan, which is not used very frequently, but at least here you can see that the activity of bone remodeling, which you measure with the bone scanning technique, is associated with the temperature. Here you see on the left side the ratio of the affected non-affected foot in the bone scanning uptake, and that was correlated with the temperature difference. I would conclude that the temperature is probably cheaper than the bone scan. But it is informative. This study was informative. With MRI, you can follow patients. There are no good studies on this topic. I apologize because there are some very nice studies, but there are no studies that help us to inform which cutoff values of MRI to use to stop treatment. And one of the reasons is shown here in this slide is if you look at the clinical findings versus the MRI findings during follow-up, as reported by Sampa in 2011, you could see that if a patient was healed on MRI, it was also in 33 patients clinically healed. So the vast majority, the results were identical. But if the patient was not healed on MRI, so there were still markers of edema, of bone edema, 4 of those patients were clinically healed. And a patient was not healed on MRI. After the observation period, there were also 3 that were not clinically healed. But for me, the problem is with the 4. Because I said before, fracture healing is also associated with inflammation. And I'm not sure if this bone marrow edema shown on MRI in a later stage is not a marker of healing instead of a marker of disease. I don't know, but I do know that if you treat the patients only based on MRI, you have a risk of treating them longer and maybe too long compared to if you use clinical science. And the same goes for FDG PET-CT. The uptake of the tracer was again in this stage of this study of Ruotolo was still increased in patients who had final recovery. The green bar shows the uptake of the tracer. The blue bar shows the delta temperature, so the difference between the 2 legs. That's the marker we use for in clinics. And you can see that the difference was relatively small, only about 0.7. Well, there was still clearly increased uptake of the marker. So there is still something going on in that foot, but you cannot detect using temperature. And I'm still wrestling with that concept. Is that disease activity or is it healing activity? And in a beautiful systematic review of Catherine Goudet, she concluded that there is lack of evidence on sensitivity, specificity, cost effectiveness, safety, and patient acceptability of any of all monitoring techniques. So we are not sure. And at this stage, we probably use temperature and clinical assessment most frequently. And of course, X-ray. So my practical advice would be continue your total contact cast until you have a temperature difference smaller than 2 degrees, healing on your X-ray, and no redness, swelling on dependency of the affected foot. That helps us greatly. How to transition out of a non-removable to a removable cast and to shoes? We have the following scheme. Once the patient has fulfilled the criteria I just mentioned, we make the cast removable. You can see here in the middle of the slide. And if that goes well and the patient walks for 2-3 weeks on the removable cast and there is no elevation of temperature, we will go to a knee-high shoe, and then usually after a year we go to shoes which are a bit lower than the knee. If temperature increases again or are other signs of Charcot activity, the patient goes back to the former offloading device. So this is for us a very simple scheme, but it means very intensive follow-up of the patients. With this scheme, we have 0 recurrences. So, how long to cast? Well, I'm not sure. But I would say I would make that decision based on temperature, your X-ray, and never forget clinic, in particular, the dependency of the leg. Thank you very much for your attention.